brains, for those that weren't there, is our loving acronym for Bedside Rounding Alliance, Internal Medicine and Neurology Residents. And this really stems from a term called neurophobia. It's just describing the general lack of comfort, lack of knowledge, perhaps with treating or identifying and treating neurologic disorders or complaints when patients come. And this stems from the fact that I think neurology is a bit of a black box. The brain is scary. Things that go wrong with the brain is scary, and yes, warrant immediate attention if severe, right? But a lot of institutions, both in the country and abroad, and in various settings, have basically maybe varying levels of neurology training, both in medical school and in the residency itself. And this is an issue because especially internal medicine residents are the ones that are primarily in, PCPs and urgent cares, are the primary medical team that sees the patient for the first time, that then end up consulting us and things like that. And they're frontline providers essentially for identifying and triaging neurologic disease and disorders. And overall studies suggested that their comfort is quite low, unfortunately, stemming from either lack of training or inadequate exposure to patients in their training, and so on and so forth. So many programs, even residencies, don't have robust neurology education. And even at our institution where we did this at the Brigham and Women's, there is at least a 2-week rotation that medicine residents come through and rotate on our services. But on 10 days of service, how much do you exactly see and get comfortable with? Some, yes. But we wanted to open this up as much as possible across all levels of trainees. So it's predominantly aimed at the general medical service in the internal medicine department. And this can include things like medical students that are rotating through, but also medical interns, senior residents, fellows if they're on, attending so they want to come. And the goal is to really break it down and make it digestible with real patient exposure. So we actually take it to the bedside. And if we identify patients that have neurologic concerns on our service or on the wards in the neurology floor, and we take whoever's on, it happens twice a month, whoever's on and is available in the evening to go see this patient, we do a quick talk on, okay, we're going to address visual deficits, or we're going to talk about aphasia, language issues. How do we approach just the eye exam, or like talking about visual deficits? How do you categorize this as, is this an eye movement issue? Is this a double vision issue? Is it a visual field issue? And then how do you go from there? Or how do you do a language exam, like more than just repetition or naming and things like that? And what information can you glean? These are some real world examples from our experience. But the goal is that they basically very minimal kind of talking about the pathophysiology, but a quick introduction, and then we show them the exam, and they each who is there goes around practicing on the real patient at the bedside. And in this way we learn both from the patients, who are also our teachers in medical education, as well as a neurology trainee. So that's the other great thing, is we draw from our own department. It's not like an extra need that we're bringing in, like we need to hire standardized actors, we need to hire extra educators or find attendings. These are trainees that volunteer their time to help other trainees in this near peer education format. And this was also really well received by the survey basically after this intervention, or this initiative at each session. And overall, they found it really quite effective in achieving the objective of, can I do a focused exam and ask focused questions about their complaint that we addressed today? And they all walked out, or mostly walked out, with improved confidence in their ability to do so in a neurologic setting, which is really great to see. And this really is great in many ways, in that it's, and we've seen in prior studies that real patient exposure and bedside teaching are much better at having things stick than a formal, didactic lecture-based teaching session. And the residents really responded to that. It leverages near-peer teaching, which allows us an opportunity to be educators as well, and also takes away a bit of the stress of thinking they're being judged or evaluated by a senior attending that's doing the teaching, right? So people have reported, unsolicited, that it's a very fun and non-threatening environment, low-key, and they're able to ask the questions, that they may think are stupid, but really are not. But, there's always a little voice in your head in these settings. That was the basic outcome. We're really excited to continue this project and hopefully expand it to, other departments, like child neurology has its own kind of spin-off, other hospitals, and doing further studies based on that in terms of how what is the consult, the type of consult to our service coming from medicine, after these interventions. So these are kind of interesting little avenues, but overall hoping to, strengthen the partnership between medicine and neurology and giving them the tools to not be as afraid and to respond appropriately.